begin our lunch program, please welcome Secretary of the United States Department of Health and Human Services, Alex Azar, in conversation with Institute Chairman Michael Milken.
Good afternoon. Thank you for joining us today on a wonderful October day here in 2019 in Washington, D.C. So U.S. healthcare spending in the latest data grew 3.9% in 2017, reaching $3.5 trillion. $10,700 for every person, according to CMS. This represents 17.9% of U.S. GDP, according to CMS data, and failure to address chronic diseases that we've looked at over more than a decade at the Milken Institute cost the United States, just the change in weight leading to these chronic diseases, more than $1 trillion a year. You've served now as HHS Secretary for nearly 2 years. How would you describe your overall approach and the administration's approach to healthcare?
Sure. So a broad question, but a broad answer for that. So 3 years into the Trump administration, we actually have a very defined, unified theory of healthcare and what we're trying to do. And what we've been doing over 3 years is progressively notching off each element. It all fits together into a very coherent vision that the President and I have been articulating. The vision for healthcare that we see, and I'd say it's often in contradistinction to an alternative model like Medicare for All or the Affordable Care Act, is a personalized, affordable, patient-centric health system that puts you, the patient, in control and treats you like a human being and not like a number. Those words actually have meaning and carry a lot of weight. They tell you what is in strategy and what is out of strategy. And there are 3 promises connected to that vision. The first is to deliver you the affordability that you need. The second is to deliver the choice and control that you want. And the third is the quality that you deserve. But the way we're actioning that are 3 key strategic legs of that vision. We've done this really, Michael, very much like a business strategy. The first is fixing financing, protecting what works and protect what works, fix what's broken. The second is paying for value in our healthcare system, higher quality, lower cost. The third are impactable health areas, such as kidney care, opioids, primary care, maternal mortality, rural health care, social determinants of health.
So we wish we had 3 or 4 hours, but we have limited time today. So let's pick 3 of them. Let's start with opioids. According to HHS, more than 10 million Americans misuse these prescriptions today, and more than 47,000 people died from overdoses. That's the bad news. But you've said opioid deaths have finally started to decline. What is the state of the opioid crisis today? And at our Future of Health Summit here, we've had a number of panels in this area. Are we finally getting traction on solving this problem? What can we expect going forward? I know a recent National Institute on Drug Abuse study showed that the healing capability here in healing communities, and I think it's been tried in 4 now, has been able to reduce opioid deaths by 40%. Tell us more about this.
Sure. So first, thanks to the Milken Institute and you for your leadership on the opioid crisis and having that as an area that you really have carved out. The good news is we are winning across every single metric that we track on the opioid crisis. Drug overdose deaths are down 5%, the biggest decrease in over 20 years. Legal opioid prescribing is down 31% since the president took office. Medication-assisted treatment, 38% more availability and use. We now have 1.27 million Americans who are getting the gold standard of opioid abuse treatment and recovery services. Overdose reversing drugs, naloxone, 378% increase in prescribing and distribution of that product. So we're making great progress. But one of the things that you mentioned, the Healing Communities Initiative out of NIH, I wish it had already proven the case. That is the goal. That's the metric we're judging it by, which is Sam Quinones, who wrote the groundbreaking book Dreamland. He said that he has seen the greatest progress when communities work together. So Francis Collins and I and the president worked together to create this really historic program. It's a $400 million program over 4 years in 4 states where communities applied and said, can you get health care, judicial system, employers, education, everybody, faith-based community, everybody working together to conquer the opioid crisis, a totally holistic, community-centric approach. We've put those grants out now to Kentucky, Ohio, Massachusetts, and New York were the winners of it. And we aim to reduce over the course of, it would be 4 years from now, 3 years of the program, opioid overdose deaths by 40% is the core metric of that, to show that it's not just like trying to boil the ocean, that you actually can, in a very material way, impact the opioid crisis in a fairly short period of time with concerted community-centric efforts.
And I know you spoke earlier of a business-type approach, identifying the problem, solving ways at that problem. And so I think one of the interesting things about it, where you're trying to concentrate in 4 communities to start and create a prototype. And how do you see that going from there? If you're successful, you see success, how soon would you attempt to move to other communities?
Well, as soon as we would get data that approaches are working, we would work to replicate that through the state opioid response grant program or through other congressional action to replicate. That's what we're doing so much of. I was just meeting this morning with Governor Sununu of New Hampshire, and New Hampshire has done just such remarkable work, having been at the cutting edge, the early stages of the opioid crisis. They've been a leader. Part of the work we do out of SAMHSA and NIH and CDC is to take what's working best in different states and localities and try to replicate that by educating other communities to take it up. We would do the same with the healing communities. This is peer review, NIH-style research, so it's going to be all open source and available for others to follow along with us.
So let's switch to kidney disease. This summer, I know the president issued an executive order to address one of the issues on end-stage renal disease, giving a better opportunity to kidney transplants and other things as a solution. I think most people are really not fully aware of how large this problem is, and I think you have really brought it to the fore and focusing on it as one of these 3 areas we're going to talk about it today. And quite possible you'll be able to substantially reduce deaths and ultimately someday costs. Tell us more about what you attempt to achieve here.
So, other than the work that we're doing right now on e-cigarettes, the work on end-stage renal disease has caused more people just on the street, friends, family, whatever, to come up to me. Kidney disease touches everybody. It accounts for $1 out of $5 spent in the Medicare program direct from chronic kidney disease as well as the comorbidities associated with it. But we really haven't touched kidney care since President Nixon incorporated end-stage renal disease as a covered Medicare benefit back in the early 70s. Nothing really has changed. And just like we're talking about with value-based care, you get what you pay for. And if you pay for people to go to centers to get traditional dialysis, center-based dialysis, that is what you will get. In America, over 80% of our patients are on center-based dialysis. Less than 20 are on home-based dialysis. It's a huge difference if you've known anyone with kidney disease in terms of quality of life. You go into a kidney care center and you get your blood basically taken out and cleaned and purified over the course of several hours, and you're drained, you're immobile, you have to recover. By the time you've recovered after a day or two, you're back in the center again to be dialyzed again. Where you could have instead nighttime home-based dialysis where it's happening every night and you don't get disabled from work necessarily. In Guatemala, over 50% of patients are on home dialysis. In America, it's 20%. In Hong Kong, it's over 80%. We're falling behind the rest of the world in terms of this option. So we're going to start paying for that. We don't get enough people on transplant. We need to start paying for that. We need to start incentivizing those who do dialysis and kidney care to get patients into transplant. We need to double the number of kidneys that are available. But most importantly, we need to keep people from advancing with their chronic kidney disease to the stage that they ever need a transplant or dialysis, which we can do with early interventions. But again, we have to incentivize providers to be doing that. So we're going to pay those who take care of patients with chronic kidney disease based on keeping patients from advancing to different stages of chronic kidney disease.
It is just astounding, and I think very few people understand what a large percent of our expenditures fall in this area and how we've fallen behind other countries. And obviously, technology and encouraging them to focus on new methods might also further drive this cost down.
Absolutely, and so we're investing at NIH and actually even in BARDA, which is our biohazard advanced research and development agency, on new methods of kidney care. We've got a program called KidneyX that has leveraged, I think it's 8-to-1 external investment into it to try to develop new next generation ways of delivering kidney care and medicines for kidney. So I think it's a very optimistic time, I think, for kidney care. It's going to change a lot in the next decade as a result of these efforts.
So let's touch something that almost every person in this country thinks about or interacts: primary care. And you've somewhat turned this on its head. How are we going to take care of people? How are we going to pay for taking care of people? Is there a way to incentivize? Is there a better system? Let's talk about this, because I think you have some groundbreaking area here that really no one has ever tried to do before, and maybe tell us why you're going to be able to do it this time.
So, that vision that I laid out at the beginning of a personalized, patient-centric approach that has you in control, it's a very different vision of healthcare. Sometimes people will think of a conservative free market vision of healthcare as one that very much is the atomized individual alone. That's not the vision that we have. We have the individual at the center, the system built around that person, but part of it is needing help, having somebody to help guide you and have aligned incentives where they're helping you through that system. And primary care is certainly one. It doesn't have to be the exclusive vehicle, but it's one vehicle for people to feel basically cared for and walked through our system. But right now, what do? You go to primary care, we pay the doctor a fee. Instead, we're going to be doing for 1/4 of our Medicare beneficiaries, changing how we deliver primary care. And at its most advanced stage, what it will do is say to a primary care practice, you commit to be accountable for the total cost of care of a Medicare beneficiary over a multiple of years. Let's just make up a number. We'll call that $14,000 a year is the total cost of care. That's hospitalizations, that's drug expense, long-term care, anything else. If you can help that patient, not through gatekeeping, not through rationing, but through advising, coaching, investing, if you can manage total cost of care to $10,000, you keep the $4,000 you've saved. If you go over, if it costs $16,000, then you're going to eat that. You'll eat the $2,000 extra. Total 100% risk sharing there. And it just will change how we do things. Think about social determinants of health. So right now, we don't pay for things like air conditioners or home meals generally, because why? If you're paying in a procedure-based model and you start paying for that, I guarantee you every American will have air conditioning at home paid for by Medicare, or have home meals by Medicare, whether they need it or not, because if it's a procedure, we're paying for it. But if instead you have a physician practice that has money, $14,000 in that example, to invest, they might say, you know what, I can keep this senior out of a nursing home and mobile, independent, and out of the hospital by investing, get her an air conditioner, have home meals delivered, maybe have a home health aide check in occasionally. I, as secretary, am not going to care how that's your money. If that's the investment you think that you should make to deliver a quality result and lower total cost of care, God bless you. So it solves so many of the things in our system. Think about how much we micromanage the practice of medicine out of Medicare and Medicaid. It's so bad that our changes have already saved 40 million hours of doctor and nurse time from 2019 to 2021 just by removing some of the red tape, not all of it. But if we move to aligned incentives and paying for outcomes and quality, like that total cost of care model in primary care, we don't have to manage staffing ratios of how many nurses to patients or doctors to patients or doctor supervision of nurses, because we're paying for a quality outcome. We can get out of the business of out of HHS telling every doctor and nurse how to practice medicine.
It creates an enormous incentive, and one of the initial trustees of our Center Faster Cures has a large healthcare practice, and he has that situation, and his patients have lived longer, healthier lives by developing ways of keeping them out of the hospital. So maybe the final question before we run out of time today is on November 1st, enrollment begins for the Affordable Care Act. A lot of controversy, a lot of discussion. Everyone has their own opinion. What can we expect for Americans in 2020?
Sure. So open enrollment, as Michael mentioned, begins on November 1st. Premiums are down 4% this year for the benchmark plan, which is the second lowest cost silver plan available in the states. On average, that's 4% down. We were down 1% last year. We have more choice available, so there are, I think, over 120 additional offering insurers in the country. We have more plan options available. We now are down to only 2 states, I think it's Wyoming and Delaware, that have only 1 plan available. So we're running it better, we're stabilizing. We've approved now 12 reinsurance pools in the states that have helped bring premiums down from where they would have been by 10 to 30%. So we're making progress, but I just want to say that's our commitment is while we have this program, we're going to run it as best we can for the American people, try to have as much choice, as many options, and as low a premiums as possible. But it's, at its base, I'm just going to, as you said, there are good faith disagreements on this stuff. We think it's a fundamentally broken program of poor design. You know, if you're a couple in Nebraska, a husband and wife, and you make $68,000 a year, you're going to spend over $30,000 on a silver benchmark plan, and you're going to have $11,000 in out-of-pocket costs. And I'm sorry, that's not affordable health insurance. That's not affordable health insurance. That's not affordable access to health care. So the simple fact is that for so many people, for millions of people in the individual market, we're doing it better, we're increasing choice, we're reducing cost. It's not delivering anywhere near the solution they were promised or anything that could be for them described as affordable access to health care. And that's our commitment, is to actually keep driving those kinds of changes, not just for people in the individual market, actually 331 million Americans across the entire system. Protect what works and fix what's broken. That's 180 million Americans, 180 million of you, probably everyone in this room almost, have private insurance through your employer or your union. What have we learned? People don't want that disrupted. They're actually pretty happy with what they've got. Is it perfect? No. Could we do a nice Milken Institute, salon dinner to come up with alternatives if we hadn't started down the third-party payer route in the 1930s? Oh yeah, we could have an interesting discussion. That's not where we are and not where we're going to go. People are pretty happy. They have settled expectations. So protect it, make it better, and fix what's broken. 60 million Americans have Medicare. They like what they've got. A third of them have Medicare Advantage, which is the private option of how you deliver Medicare. They like what they've got. Protect what works, make it better. Help get Medicaid if we could get a willing Congress to be on a sounder fiscal footing for the future, because it's going to bankrupt so many of our states over time. But do that when we can. And then we have the Affordable Care Act, which for 10 million Americans in the exchanges, we spend a lot of time talking about what's an important but still a part of our healthcare system. And we are trying to actually fix the infrastructure through transparency, interoperable health IT, data availability, value-based payments across 331 million Americans to fix the whole system.
Well, one of the things, you are a great communicator, and I think hopefully you will lead in this area. I think back over the last few years, and in California, former Governor Brown formed a commission that was called Personalized Medicine Commission. and I was one of the commissioners. And after about 9 months, we changed the name from personalized medicine to precision medicine, because with data, we could know what might work for you before you take it and what wouldn't work. At the end, a year later, before the report was, we changed our name again to personalized health. Can we prevent you from getting a disease? And so at the conference today, we have our Center for Public Health represented here. We have our Center for Strategic Philanthropy, our Faster Cures Center, our Center for the Future of Aging, our School of Public Health at GW. And more we see a movement here of moving to prevention. What role do you see HHS taking leadership in that? Can we move to prevention rather than treatment?
So certainly there is the work that we do to educate all of us. That only takes us so far. I've become a big fan of behavioral economics over the last many years, just thinking about how we all engage in behaviors that are not economically rational from even a self-interested perspective. But we do it for some immutable laws of human behavior and psychology. It just happens, like how we overvalue present, and we basically have a very high discount rate. And so we make some really stupid long-term decisions in prevention, whether it's diet or smoking or e-cigarette use or whatever. And those are things I think that you can't just educate your way out of. We need to think about the incentives. That's where I'm so excited if we can get the aligned incentives through, like the primary care demonstration. If we fix incentives on kidney care that actually will prevent chronic kidney disease advancing. If we can figure out maternal mortality, how we can get an aligned incentives around labor and delivery, around prenatal care, and around postpartum care, we can actually create a holistic way of preventing maternal mortality there if we get OBGYNs, mid-nurse primary care actually incentivized to make sure that women have healthy deliveries and stay healthy after birth.
Well, one, we first want to thank you for taking this position. You know, I learned 50 years ago, as we began our philanthropy, that no good deed ever goes unpunished. And so, not everyone wants to take the call to serve, and we want to thank you for that.
It's my privilege. Thank you.